I thought about taking it as well. We'll go ahead. We'll go ahead and get started. It sounds like we're at time. Jennifer Richards. I'm an assistant scientist with the Center for American Indian Health at the Johns Hopkins Bloomberg School of Public Health. I just want to welcome everyone to this webinar and thank everyone for joining. This webinar is part of a 4-part series of an initiative that our center is working on with the goal of increasing COVID-19 vaccine acceptance and uptake, as well as other COVID-19 prevention behaviors for Native communities. So we're grateful to everyone for joining this first webinar. The topic of today's webinar is building, as you can see, building COVID-19 vaccine confidence in Native communities. Really briefly, just some housekeeping. We're doing a pre-webinar survey, so you might see that on your screen. It takes just a few seconds. There's no right or wrong answers. We're just asking everyone to complete it so we can kind of gauge everyone's knowledge of COVID-19 vaccine hesitancy before the webinar. And then Anna will also send a post-evaluation. It's going to be just as brief. So we like to ask everyone to do that as well. Before we get started, I wanted to introduce our 3 speakers. Today we have Dr. Nina Ritchie. Dr. Ritchie is a study physician with the Johns Hopkins Center for American Indian Health at the Chinle, Arizona site and works with the center's infectious disease team. Nina is board certified in both internal medicine and pediatrics and worked as a medical officer at the IHS Chinle Comprehensive Healthcare Facility prior to joining the center. She has served the Chinle community for over 10 years. And as I'm talking, we're gonna link to longer bios and some of their research projects as well. So feel free to look at that on your own. Next, we have Rupali Lemay. Rupali is an epidemiologist at the Johns Hopkins International Vaccine Access Center, or IVAC, and an expert in vaccine hesitancy. Rupali is the director of behavioral and implementation science for IVAC and a full-time faculty member at the Johns Hopkins Bloomberg School of Public Health. She also serves as the associate director for behavioral research at the Institute for Vaccine Safety. In her 15 years of working in global health, she has worked in more than 20 countries. So go ahead and feel free to go to the link as well. And then last we have Dr. Sophie Neuner. She's a research associate with our Johns Hopkins Center for American Indian Health and a proud member of the Karuk tribe of Northern California. Sophie has served as medical and public health advisor to the Karuk tribe's COVID-19 incident management team and post-residency she plans on serving Native American women and families as an obstetrician and gynecologist and researcher through approaches that are culturally congruent and honor Indigenous sovereignty. So thank you to our 3 speakers. Without further ado, I'll go ahead and pass it over to Dr. Ritchie and she can go ahead and get started. Thank you.
Great. Thank you so much for having us. Good afternoon, everyone. We're really excited to have this opportunity to discuss this really important information with you today. So let me just make sure I can actually click through slides because I am not the most computer savvy. Let's see. Oops. Okay, I've got control of the slides. Sorry about that. So I'm just going to dive right in. Today, we're going to focus on understanding the motivations and drivers of vaccine hesitancy and how this impacts COVID-19 vaccine uptake. And we're also discussing communication approaches to building vaccine confidence, specifically the role that community health representatives and public health nurses play in building vaccine confidence, as well as approaches to answering frequently asked questions about COVID-19 vaccines. We're going to provide a general overview of COVID-19 and vaccination. We're going to discuss the drivers of vaccine hesitancy and vaccine acceptance in the COVID-19 context, as well as effective ways to communicate COVID-19 vaccine information. And we'll close with some frequently asked questions and helpful answers towards the end of our presentation. So as many of us are aware, COVID-19 is the disease caused by the novel coronavirus known as SARS-CoV-2. It's spread person to person by way of respiratory droplets, and symptoms can include fever, cough, trouble breathing, as well as more general symptoms that are seen in other viral illnesses such as aches, pains, upper respiratory symptoms such as nasal congestion, runny nose, even GI symptoms, gastrointestinal symptoms. And one of the more specific symptoms that many complain of is loss of taste and smell. Survivors, those who have recovered from infection, experience long-term effects, symptoms that can last weeks to months after recovery from the initial infection. So this table illustrates how COVID-19 has disproportionately affected Native communities. As you can see all the way at the left hand of the slide, in the first column, Native communities have experienced nearly 2 times the case rate, over 3.5 times the hospitalization rate, and almost 2.5 times the death rate compared to white non-Hispanic individuals. I'm sorry, I didn't mean to click. I got a little click happy with the slide. Let me see if I can go back. Oh, I am just not very good at computers, am I? There we go. Sorry about that. I just wanted to point out that race and ethnicity do represent risk markers for other underlying conditions that can affect health and susceptibility to this virus, including socioeconomic factors such as housing conditions that can increase exposure to infected individuals, as well as holding frontline and essential occupations that can increase exposure. Okay, let's see if I can click again. Great. So how does the vaccine work? Vaccines stimulate the body's immune system to make antibodies, and these help the body recognize and fight invaders. The vaccines are made from synthetic, laboratory-made pieces copied from the SARS-CoV-2 virus, not the entire virus. Therefore, the vaccines cannot cause infection or cause you to get COVID-19 or cause you to test falsely positive for COVID-19. I really like the car analogy in this situation. A tire, a steering wheel, and a speedometer do not equal an entire car. They cannot drive you to point A to point B. Similarly, the laboratory-made parts that go into the vaccine do not equal the entire virus and cannot make you sick. I think it's helpful to understand the rigorous stages or phases of clinical trials that any new medical product, medication, or vaccine must go through before it can be considered for emergency use authorization and or licensure by the FDA. So here we've outlined the different phases. There are 3 phases to a clinical trial. Each of these last anywhere from 18 months to over 2 years. As you can see in phase 1, this is usually a smaller number of volunteers, usually less than 100 people. And in this portion of the phase, we're testing the safety of the product and whether the body can tolerate this product, what kind of side effects there might be. After there's enough safety information from this portion of the vaccine trial, from this phase 1, then it moves on to phase 2. This is usually a few hundred to a few thousand volunteers. And this is the portion of the trial where we see what the immune response is to the product, the vaccine product, and we monitor for safety as well. Once there's enough information from onto phase 3, and this portion of the trial is really where we are testing the efficacy. Does this product prevent infections or help reduce the severity of disease? And the number of volunteers in this portion of the trial in the phase 3, it's on the order of thousands, tens of thousands of people that have volunteered. And I think it's really important to note that, these are the traditional phases of any clinical trial, and all of these phases have been pursued or have been, what's the word I'm looking for? They've been followed for the COVID-19 vaccines as well, that no phases have been skipped. Instead, these phases have been overlapped. So in the time of a historic pandemic, when we don't really have the luxury of going through 2 years of phase 1, 2 years of phase 2, 2 years of phase 3, we really can't wait 6 years to find an efficacious, effective vaccine. This is where we get more hands on deck, more people evaluating and analyzing the safety data in real time, to determine whether or not we have enough information to move on to the second phase. And so while the first phase is finishing up, we've moved on to phase 2 because we have enough safety information to deem it appropriate to move on to phase 2. And the same thing for phase 3. There was enough information in the phase 2 trials, enough safety data to deem it appropriate to move on to phase 3. Phase 3 trials are still following their participants, even now that we have emergency use authorization for the current vaccines. So we really just want to emphasize that no phases are skipped, all phases are done, and that information is being evaluated in real time so that phases can be overlapped and make them more efficient. Okay. So currently, as many of you are aware, there are 3 vaccine products that reached emergency use authorization by the FDA. 2 of them are the Pfizer and Moderna vaccines. These are mRNA vaccines that require 2 doses. They are available for Pfizer for individuals who are 16 years of older, and for Moderna for those who are 18 years of age and older. Both of these have been proven 95% efficacious against COVID-19 disease, and especially severe disease that requires hospitalization or even death. And the third one is the Johnson & Johnson adenovirus vector vaccine, which has also been shown to be highly efficacious against preventing severe COVID-19 infection. So we'll talk more about this later, about vaccine allocation and distribution in Native communities, but briefly I wanted to mention some of the strategies being used for vaccine rollout. Mass vaccination events are a highly effective way to reach many people in a limited amount of time. These events can be hosted at local clinics, schools, assisted living facilities, chapter houses, many community spaces. They can take the form of a drive-through event. You can get upwards of 1,000 doses or even more administered during these events. And it also can keep many of these individuals outside in places that are well ventilated, especially in this current day and age where we need to maintain social distancing and be in well ventilated areas. You can also access vaccines through routine clinic appointments, and then some elders and other homebound individuals are being reached via home visits. Now I think we are going to switch over to Polly.
Yes, no, thank you so much, Nina. I hope you guys can hear me. Okay, good. Okay, good. So as Nina mentioned, and I think, sorry, as I was introduced, so I've been studying vaccine hesitancy for about 7 to 8 years now. That's primarily here in the United States, but also globally. And so I'm going to touch base on a couple of things. So the first thing I want to focus on is, what are the drivers, right? What are the reasons why people are reluctant or have concerns about a vaccine within the context of COVID? So if we can go to the next slide, please. Great. So one of the issues that we are struggling with, as those of us that work in this space, is that as more and more COVID vaccines become available, we have the 3 products or 2 products. One is on pause here in the United States, but as other countries are trying to determine what types of vaccines are available, how do we assure really the public that what we have been doing and what the scientific community has been working on and the recommendations really reflect the latest evidence, right? And are very scientifically based. This has been a challenge for us, particularly within the context of COVID and vaccine acceptance, because the problem has been really exacerbated. We're in the middle of a pandemic. There's a lot of uncertainty. It's a dynamic situation. And as a result, recommendations change. One thing that we hear a lot that has contributed to hesitancy is that individuals feel as though the public health community, and that includes the healthcare system, is not really quite clear with regards to the science. From our perspective, the reasons that recommendations are updated, and that's because we gather data, we look at the data, we update recommendations to reflect the data. However, the public doesn't view it like that. So that's been a huge issue, this idea of scientific uncertainty. A second issue we've had specific within this context is this idea is that individuals are talking about not only the pandemic with regards to non-pharmaceutical interventions, but also vaccine interventions. And this is really being led by mouthpieces that are really politicians rather than experts. This has caused individuals to believe that there is a perception that the whole process, the vaccine development process, the rollout, the administration has been politicized. As a result, this increases bias in individuals' decision-making related to vaccines and really gives them pause and more concern. The other issue that has come up, and we've heard this through a number of the groups that we have been working with, is that there is a lot of misperceptions and misunderstanding of Operation Warp Speed. You know, you talk about why are names important. Operation Warp Speed doesn't necessarily convey sort of a very safe and rigorous and thorough process to a lot of individuals. And so there's a lot of questions that we have had starting from last year when the pandemic was started in March, that the way that these vaccines are developed and approved, even though they're under an emergency use authorization, does that mean they're safe? Are we cutting corners? And that has led to a concern as well. If we can go to the next slide. So I want to show you very briefly what you're seeing on the screen is essentially a graphic that looks at whether the question is US adults were asked whether they would get a vaccine if one became available. It's tracking from February of last year of 2020 to September of 2020. And what this is essentially showing us is that if you look at the tealish line, that's men, or sorry, the lighter blue line, that's men, the green line is all adults, and the red line is women. So at the beginning of the pandemic, when it was first determined and established that we were having a pandemic, we had pretty high rates of the proportion of individuals that said that they would get a vaccine if one became available, right? So we're looking at, if we look at all adults, it's somewhere, let's say around 64%. We then had key activities that happened during last year, including the fact that we hit 1 million cases pretty rapidly. We then saw the death toll increase to 100,000 by the end of May. We hit 2 million cases, and the number of cases doubled very exponentially in our pandemic here in the United States. And at the end of essentially September, beginning of September, sorry, you can see essentially that confidence and intention to get a vaccine has declined. So if I extend this graph out even further, and if I look at other survey data that have come in that have looked at intentions to get a vaccine, it has dropped even more. However, one thing that I will say that to us is a bit more of a silver lining is starting in December, when vaccines started to be administered, we started to see those numbers go back up. And part of that has to do simply with the fact that individuals were infected with COVID, and were dealing with it on a day-to-day basis, making it very salient and making it very top of mind, which really, in our opinion, nudged people towards vaccine acceptance, especially amongst those that may have been hesitant in the past. So if we go to the next slide, I think I'm turning it back over to Nina.
Thank you. So additional layers of complexity that can lead to skepticism and distrust, specifically among Native communities, include historical traumas endured, unethical research with Native nations that has occurred in the not so distant past even, as well as ongoing systemic racism and disparities. Our goal is to build confidence around COVID-19 vaccines to protect our communities. In order to do this, we must understand the past and current systems of discrimination and oppression that have led to the inequities and disparities observed in Native nations during this pandemic. So in a recent survey of almost 1,500 individuals representing over 300 tribes across 46 states, it was found that 75% of respondents were willing to receive a COVID-19 vaccine. 2 out of 3 of the respondents willing to get vaccinated were confident that COVID-19 vaccines were adequately tested for safety and effectiveness among Native people, but 75% of those willing to get vaccinated still had concerns about potential side effects. So of the 25% of people unwilling to receive a COVID vaccine, the main reasons cited were they thought the vaccines moved through trials too quickly. They thought the COVID vaccines were dangerous. They thought the vaccines were inadequately tested for safety and effectiveness, and there were effects. Interestingly, of those unwilling to get the vaccine, 90% of them felt COVID to be a serious threat, and 75% of them felt they were at risk of infection individually themselves. 64% of them said they would receive the vaccine at some point in the future. And many individuals cite that they want to wait and see how their peers handle the vaccine, or if there are any long-term effects that haven't been seen in the trials yet. So it's completely normal and expected for there to be questions and concerns about vaccines, especially new ones. And this is where we have an opportunity to effectively communicate accurate information to build confidence. So there are essentially two paths that vaccine hesitancy can take, and this is where community health representatives and public health nurses can play an important role in communicating with patients to hopefully turn that hesitancy into confidence. And circling back to the survey, it was found that the primary motivation for participants who indicated willingness to get vaccinated was a strong sense of responsibility to protect the Native community and preserve cultural ways. And we're going to switch back to Rupali.
Thank you, Nina. So with regards to some of the arguments, so previous to the COVID pandemic, we had been studying and trying to understand why people would not get the vaccine. And in general, what we were really seeing was, again, pre-COVID, people had concerns about vaccine ingredients. We always heard, well, is there formaldehyde in a vaccine? What does that mean? We also heard individuals were concerned about the vaccine schedule. And essentially, this is really referring to childhood vaccines, meaning parents were concerned that you're giving my baby this at 0, 1 month, 2 months, 4 months, etc. It's too many shots at the same time. The other main concern that we saw, okay. The other concern that we saw was a misperception of that there was a link between vaccines and severe adverse events. So for example, even though that this supposed link between vaccines and autism has been soundly refuted in more than, I think it's more than 12 studies, it's been probably close to 40 or 50 studies at this point, this misperception still remains that vaccines may cause autism, and that is an issue that we hear. Again, pre-COVID, one of the other concerns and drivers as to why people would hesitate is really this issue of a low level of risk perception. People did not feel that the vaccine preventable disease that the vaccine is intended to prevent was either severe enough or that they weren't susceptible to it. So we heard a lot from individuals, things like, why do I need to get the polio vaccine? I've never even seen polio in my life. The other piece, again, pre-COVID, is historical and current mistreatment and mistrust of researchers, as well as the US federal government. So if we go to the next slide, the question really is, how have these changed over time? On the right, what you're seeing here is the way that we conceptualized vaccine hesitancy. So one thing to be very clear is that vaccine behavior falls on a continuum. It's not a yes, no. We generally have people that fall sort of in that middle category, if you will, what we call ambivalence, where they sort of are comfortable and open to persuasion. On the very left-hand side, we have individuals that refuse all vaccines. That's a very small proportion of individuals, at least in the United States. And then on the right side, we have individuals that are essentially pro-vax, that very much not only accept vaccines, but advocate for vaccines, right? So the way that these have shifted is that we have continued to see, started after COVID, that there is a lot more distrust and there's also a lack of confidence. Part of that has to do with the issue, as I mentioned before. There is confusion about the way that the clinical trial process was rolled out. The other issue in relation to that is that we get a lot of questions with regards to how are clinical trial participants recruited, for example. Are they representative of the population? Do they have comorbidities like other individuals in the population? And so that was a real challenge to explain. The other issue that's happening with distrust as well as lack of confidence is this idea that the current products that we have were actually administered and approved under an EUA. People have lots of questions about the EUA, and they tend to perceive that essentially, because it was an expedited process, that there were regulatory corners that were cut, even though that is not the case from a safety and efficacy perspective. So the second issue that we've really seen is misinformation, and I'm sure you all are very aware of this. This has primarily been fueled by social media. There's a lot of misinformation that is circulating that individuals have questions on. There's also specific pockets of the population that is more susceptible to misinformation, which is a real challenge. Several of us have been working very closely with social media platforms, including myself, with regards to how do they change policies related to misinformation so that we can make sure that we are really mitigating the effects of this misinformation, particularly on individuals that are susceptible to it. The other issue that has happened more and more, again, over the context of this pandemic, but has been building for quite a bit, is called the polarization of attitudes. And what I mean by that is 10 years ago, you may have been friends, close friends with individuals that from, let's say, a political ideological perspective, you and them did not see eye to eye, right? That has changed quite a bit over the last 10 years. We're starting to see more and more polarization. So the question is, how does that really affect vaccine behavior? The problem with that is that if you're essentially only communicating and talking to those that have the same belief system and attitudes that you do, you're essentially in something that's called an echo chamber. That means that you're not going to see any information that's going to be innovative. And the way that innovation happens, whether you're talking about a product, an idea, a concept, is that you really have to talk to people that think differently than you do. And so the problem becomes is because you do not talk to others that do not, believe in the same way that you do, is that you dig your heels in. From a psychological perspective, it's called cementing. Your attitudes become more immovable, if you will. And that's a real challenge for those of us that are trying to work people towards nudging them towards a vaccine. The other issue is that we're starting to see is that more and more, historically, hesitancy does not include access as part of its definition. However, within the context of COVID, this is becoming a real issue. We've talked to a number of individuals that have said, it was so hard for me to get an appointment. I don't know how to navigate an online system, and therefore I don't trust the product. So essentially, distrust and confusion with the way that they were signing up for vaccines has led to hesitancy, which is a whole other concern for those of us that study and that are in this space. If we go to the next slide, please. So I'll give a little bit of background to explain a little bit of these and to illustrate some of these further. So when I'm talking about distrust and lack of confidence, so I personally have been working with African Methodist Episcopalian congregations within the Zion Church. And over the last 3 months, and this has changed now, I've met with about 30 congregations. It's been pretty busy here in the Mid-Atlantic. Essentially, I speak to about 30 to 60 members in each meeting. These members tend to be a little bit older, so they're usually 55 and older. And there are some key concerns that come out. Within the context of distrust, again, as I mentioned, there are concerns about the vaccine development process and the clinical trial process, the timing, the recruitment. Again, if people had comorbidities or not like they did. A second piece related to distrust is this healthcare system distrust due to not only history of medical experimentation, but current interactions with the healthcare system. So perceived discrimination as well as racism in current modern healthcare access. In terms of confidence, the number one question I get when I go to these churches is the vaccine safe for Black people? How can you tell me with certainty that it is okay for individuals such as myself to accept the vaccine? Then the other issue related to that, as I mentioned, is that a lot of individuals want to know that if people in the clinical trial were like them, did they also have diabetes? Did they also have high blood pressure? How did the vaccine affect them differently from not only an efficacy perspective, but also a safety perspective? If we can go to the next slide. And I continue on this theme. The other populations that I have been working with, besides African American Methodist Episcopalian churches, is also with incarcerated populations. And also this has gone up. So over the last several months, I've essentially met with 5 different prisoner populations. These populations are typically a little bit younger. So they sort of are more towards the 21 to 35 years of age. These are primarily comprised of individuals that identify as either Hispanic or African American. As you can see with regards to the concerns, they're pretty similar to what we found with African American congregations, that they're distrustful of the vaccine process. There's also issues with distrust because of medical and history of medical experimentation. But in this group, another concern that has popped out for us is this lack of confidence that people don't think that the vaccine is effective. There really are concerns about the efficacy of the vaccine itself. And that's one reason why individuals are opting out from getting the vaccine. If we can go to the next slide. Thank you. So let me switch to misinformation and disinformation. So in 2018, dictionary.com, their word of the year was misinformation. And misinformation is when people spread misinformation, they believe the information that they're sharing. You compare that and contrast that to disinformation, which is essentially crafted and disseminated with the intent to mislead others. So an example I can give you to illustrate the nuance between these two terms would be if a political leader claims that COVID-19 is no worse than the flu, despite knowing that that is not true, that is disinformation. But then when an individual hears it or sees it on Facebook and shares it, that is misinformation. If we go to the next slide, the challenge with this misinformation, as you can imagine, it's very much been fueled by social media. You know, I work not only here in the United States, but also globally, and WhatsApp is a huge issue for us. Facebook, Twitter, they're all huge, huge problems for us with regards to misinformation and disinformation. Now, if we move on to the next piece in terms of polarization, what you're seeing here is essentially a snapshot of links between vaccine-related clusters that were on Facebook in 1 year in 2019. So if you look at the red dots represent individuals that have anti-vaccine attitudes. The blue dots represent individuals that are pro-vaccine, and then those that are green or bitter are undecided. And the argument here with regards to this paper and subsequent analyses of looking at networks is that we're starting to see more and more polarization. There's less likelihood to be entangling between these two different groups. And again, as I mentioned, if we go to the next slide, what that leads to is that leads to something called an echo chamber. Oh, maybe I don't have that slide, but anyway, what it ends up happening is that you end up essentially preaching to the choir, if you will, right? So you hear something about a vaccine, you say, this is the reason I don't want to get a vaccine. I think it will cause infertility. Let's say that's something that you believe. You're essentially then communicating that to other people in your network, in your social network that believe the same way. So no one is going to challenge you on that myth, which again leads to a cementing of attitudes. So then the question remains, if we go to the next slide, how should we communicate? What are some lessons learned, right? Let's not all do doom and gloom. Let's talk about some positive ways in terms of how do we mitigate some of these issues. So if we go to the next slide, you will see here, there's some cornerstones that we have really looked at. And I think some of them seem very basic, but you would be surprised at how many people that are working in this space don't really take the time to think about all of these. As I mentioned, the biggest issue with regards to driving vaccine hesitancy is trust. And trust really underlies a lot of this. So distrust in the healthcare system, distrust in the vaccine process, distrust in our politicians, you name it, it has come out. Another piece in terms of how do we announce or what's some cornerstones of communication principles we should follow is announcing early. An example I can give you here is that even when they were trying to determine early on in the pandemic whether or not a shutdown was going to happen, sort of at the state level, some governors came out and said, you know, we likely are considering this option. We may have to shut down and have a curfew. And just being open about that was really important. That goes hand in hand with the next principle that's bulleted here, which is transparency and being upfront about what we know and what we don't know. One thing that we did with some of the advice that we have been giving governors as well as mayors is that for every single press briefing that a politician delivered, to be very clear about here's what I know today, here's what I don't know, and here's what I'm going to ask you to do. So to be very transparent about what the state was doing or the city or the county, to make people really feel as though you're being transparent about the process and really being transparent about the action plans moving forward. The fourth, I'd say, cornerstone of communication is listening. As I mentioned before, we've been living in uncertainty for a long time. People have increased anxiety. One way to reduce that anxiety and that feeling of uncertainty is to just listen and be empathetic. Individuals are struggling with a lot, not only from, I think, the impacts of COVID from a health perspective, but we're seeing that from an economic perspective, as well as a social perspective. And so it's very important to just listen and allow people to be able to talk and process what they're feeling. We go to the next slide. Thank you. A few other things. These are just some of the things that, some examples. So for example, with regards to trust, One thing that has come out very clearly is one way that will help build trust is how do we include communication regarding the side effects. The pause of J&J is a very, very good example that we have seen illustrated. Pretty incredible that a pause was indicated here in this country with 6 cases out of 7 million. So the odds here of 1 in 1 million of experiencing this rare blood clotting disorder, but that's to essentially show that we're taking safety very, very seriously. With regards to announcing early, another example, an illustrative example of this is sharing what you know. For example, President Nez's town halls in Navajo Nation is one example of this. From the transparency piece, sharing trial results and information, one thing I've heard from colleagues on the other side of the world is issues with regards to trial data from some of the other vaccine products and not seeing that trial data. And that really causing I think, a lack of confidence for a number of individuals, even from a provider perspective, that feel uncomfortable promoting a specific product because they haven't seen the clinical trial data. And finally, as I mentioned before, listening and making sure that you're working hand in hand with the community to develop that messaging. One thing that we have seen even prior to COVID is that we've seen a decline in trust with healthcare providers. What does that mean? That means that messengers, individuals that are promoting the vaccine, maybe the best messengers might not be public health individuals. They might be other community leaders. They might be religious leaders and faith leaders, for example. If we go to the next slide. Great. One other piece that we have spent a lot of time studying, and we actually wrote a book on this, was a step-by-step process of how do we communicate to increase trust. So one way you can think about this is that let's say you have an encounter, you have a person come that has a concern about the vaccine. Perhaps they bring up a misperception and they say, I have heard, unfortunately, that if I get the vaccine, that the vaccine is inserting a microchip into my leg. The best way to deal with this is to essentially not correct the misperception. I think the instinctive way for many of us in the manner that we choose is to try to quickly provide correct information and say, you know what, actually, there's no microchip in the vaccine. But unfortunately, what we have seen is that this can cause something called a boomerang effect or backfiring. So instead of dealing with that specific and correcting that misperception, the better option would then be to automatically do something called pivot, which means we would then pivot to focus on the disease, right? So let's say someone comes to you, has a misperception or a myth. Instead of addressing that, immediately just say, let's talk about risk perception. Let's talk about severity of COVID. Let's talk about susceptibility of COVID. From there, it's very important to think about how do we use something called behavioral economics, which is really, in this case, using nudges and defaults. So vaccination is still the norm in this country. Vaccination is still the norm for COVID-19 vaccines specifically. So one way to encounter that, to really focus on that encounter would be, instead of saying, hey, you're eligible for a COVID-19 vaccine, would you like to get one today? Shifting that slightly, and instead framing that to say, you are eligible for a COVID-19 vaccine, I'm going to go get it ready for you. So you automatically make the assumption that the individual is accepting of a vaccine because it is the norm. The other piece I would say is, again, building trust through empathy. I cannot stress this enough. I've worked with, I think at this point, thousands of providers, and how do we make sure that we are being empathetic with our patients? It is so incredibly important, again, particularly in the context of this time, because we're in such a time of uncertainty. We go to the next slide. A couple other ways. So besides thinking about that step-by-step process, some of the appeals, i.e. framing that we've used in messaging that has shown to be really effective has been communicating to the benefit of the community, meaning that you essentially have a message that says that the desired behavior is not just an individual choice, but it's important for the public good, right? One way that we can think about this is we can say, I get vaccinated because I care about my grandma, right? That would be one example of an appeal that really appeals to the community, to the benefit of the community. The other issue related to this is that it also invokes risk by essentially telling people that if you don't engage in the behavior, i.e. you don't get a vaccine, you're putting people that you know in the community at risk. And that really sometimes nudges people towards understanding, saying, you know what, it's not necessarily about me, it's about protecting my community. If we can go to the next slide. Great. Another piece that we have seen is how do we appeal to aspirational norms? One thing that we have been finding, let's say, particularly in Baltimore, for example, is that individuals really want to see someone that they aspire to be getting the vaccine, right? For example. So one way is how do you make it normative? Take a picture of yourself, take a picture of a community influencer, post it on social media and say, hey, I got the vaccine. This was my experience is incredibly important for a lot of these populations because many populations are very, very, very much looking to other people to help them inform their choice, right? Part of that has to do with that it's a new product, there's uncertainty. So if they can look at someone and say, you know what, I really trust that person. If that person is getting it, that really instills confidence in me and helps nudge me towards an acceptance of a vaccine. Really, really important. We go to the next slide. The other piece that's important from a messaging perspective is how do you make the ask, i.e. the call to action for the message that you include, how do you make it concise, uncategorical, and unambiguous? So one example I can give you is that let's say that you have a shared kitchen at work, and let's say there's a sign there that says clean after yourself. The problem with that ask is that it is not concise, it's not unambiguous. Clean after yourself in what way, right? A better way to phrase this would be, do not leave dirty dishes in the sink. And it's really incredible when you think about the language and you think about what you're asking individuals to do. How do you make it unambiguous so that there's no misperception of what you're asking? How do you make sure it's concise? And how do you make sure that you're essentially really telling them what to do in an easy to way manner? We can go to the next slide. I think I'm almost done and I'm going to hand it over. But another piece is also appealing to community values. Again, I think in a lot of the communities that you all are supporting and that you're working with, this is really an important underlying value and belief system. And so it's important the ways in which the messaging is communicated and developed within these types of communities is, for example, there's a great example, be a good ancestor, keep our communities healthy. Our families matter, keep wearing masks to protect loved ones, and protecting our communities is our priority. So what are ways in which that you can create messages that really appeal to community values? I think if we go to the next one, let's see. Yes, okay. So I think I'm gonna hand it off. I think that's it for my piece.
Thanks, I think it's me again. So where are we now with vaccine uptake in Native communities? Native nations, compared to states, are unique in that they have the autonomy to determine how they want to receive their vaccine allocations and how they want to distribute them in their communities. Many nations opted to receive their vaccine allocations through the Indian Health Service instead of through the state. And this distribution approach of IHS facilities working closely with tribal facilities, both of which tend to have robust public health departments in their specific service units, has translated into a very efficient rollout. Many tribes also determined how they wanted to prioritize different groups. Many put native language speakers at the front of the line. Navajo Nation, for example, they also included traditional practitioners working at IHS facilities. And specifically in the Chinle service unit, our very first recipient of the vaccine, the Pfizer vaccine that was distributed, the very first recipient in the Chinle service unit was one of our native healers at the hospital. And now, because the rollout has been so efficient, many tribal communities are making vaccination available to all eligible adults. So it's difficult to calculate a precise percentage here since both the numerator and denominator can vary, whether or not you're only considering individuals that live on the reservation versus those that live off-res and travel. But some estimates of vaccine coverage, those receiving at least one dose among eligible individuals are as high as 92% on the Navajo Nation. And if you compare that to the general US, it's only about 21%. So I think it's just a testament of how well vaccine rollout has been in Native communities. So just as the media was quick to report on how Native communities have endured so much during the pandemic, they've also been quick to highlight the successes that these communities have experienced with COVID-19 vaccination. And here's just a few headlines that have been in the news recently. So this graph demonstrates the fluctuations in daily cases on the Navajo Nation throughout the course of the pandemic. You can see where the two major surges occurred, as well as where strict lockdowns were implemented. During the prolonged peak of the recent and most significant surge, you can see where vaccination rollout started on the Navajo Nation. So it's really kind of like right at the end of that plateau of the peak. And you can see what a dramatic decline there was in cases. And this next graph, let me see if I can, illustrates the rates of COVID-19 hospitalizations in the US among different racial and ethnic groups. As you can see, the teal line that is the most prominent with the highest peaks represents American Indian and Alaska Native hospitalizations. This graph makes the disparity abundantly clear that Native communities experience significantly more morbidity than any other racial or ethnic group in the US. However, now that there has been so much vaccine coverage in Native communities, they are currently the least likely individuals to be hospitalized from COVID-19 at this point in time. And again, this is a great testament to how effective the vaccines are at preventing severe illness from COVID-19, especially in communities who historically experience more severe illness and mortality throughout the course of this pandemic. So, by reviewing all of this information, we're really hoping to emphasize that vaccines are now one of our best tools to fight COVID-19 in our communities and to support the role that community health representatives and public health nurses play in their communities. And hopefully through effective communication, knowledge of vaccines in COVID-19, as well as their trusted role in the community, that community health representatives and public health nurses can help turn vaccine questions or hesitancy into vaccine confidence and hopefully avoid refusal. And once confidence is built, they can help facilitate access to vaccines because they know what's going on in their community, whether it's a drive-through event that's happening or what the access is like at the local clinic, or if there's a school-based vaccination clinic. I mean, they really have their finger on the pulse of what's happening in the community. And so I think at this time, we're going to switch over to Sophie.
All right. So I am also really happy and honored to be here with you all today. Before we launch into the FAQ section, I did want to highlight a question that we had in the chat. So Eric asked, what are recommendations for incentives to get vaccinated, like t-shirts, cash, and extra time off? And Rupali did give us a little answer in the chat. Would you like to speak to that briefly before we launch into our FAQs?
Sure. No, happy to do that, Sophie. I tend to shy away from these. I also work very closely with bioethicists, and so I feel like I get a lot of input from them. I think the key is that the incentive can't be seen as coercive, and what I mean by that is that, for example, I know there was some debate, some of the grocery stores, for example, were going to pay their employees $50 to get a vaccine. From sort of a, coercive perspective, that could be seen as coercive because most of these individuals do not make more than $8 an hour, for example. So I think the key has to be the incentive has to be small enough that people do not feel as though they need to do it because it's leading to a coercive action. So I know a little challenging, sorry, and I know there's a lot of work that's been done in this space. Oh, and I think there's a follow-up. Sophie, do you want me to take this one? Sorry. Would you consider travel? I think that is a great incentive, right? Because you're not paying someone extra, I guess is what I'm saying, to get the vaccine. You're essentially offsetting the opportunity costs for allowing them to leave their work to get the vaccine. So I think that's a great idea.
Okay, thank you so much for those excellent answers. We are going to launch into an FAQ section now, and this FAQ section just sort of serves to talk about some of the most talked about questions, some of the questions that we've all been getting at the Center for American Indian Health. I'm sure you all have been receiving tons of these questions in your communities as well. And we'll just discuss like certain approaches to answering those questions. That being said, we are ready to take any of your questions. So please, as we go through these FAQs, think about anything that might come up for yourselves or for your communities. So one thing I've been hearing a lot is people are really concerned that these new mRNA vaccines, meaning the Pfizer and Moderna vaccines, change genes. Now, it's important to emphasize that while this mRNA technology is new-ish, it's been developed and researched for decades. So this is something that is very, very long in the making. And the matter of fact is that the mRNA in those vaccines actually cannot combine with DNA to change our genetic code. The way you can sort of imagine it is imagine your cells as an egg. The egg white is the so-called cell plasma, and that is where all of the proteins in your cells are synthesized. The nucleus, which in this analogy is the egg yolk, is what contains our DNA. And these mRNA vaccines don't actually enter the nucleus, and they cannot combine with the DNA to change genetic information. They're also relatively fragile, so they hang out around inside your cell for about 72 hours, telling your cells to produce the spike protein, a similar protein that is on the novel coronavirus. And basically that helps your body mount an immune response. So you can imagine it's kind of like telling your cells to dress up as SARS-CoV-2, generating an immune response, but it's not actually causing COVID-19, as Nina explained with her amazing car analogy. Another question we've been getting very frequently in the last weeks is, how does the J&J vaccine work? So the J&J vaccine uses a sort of different technology. It uses an adenovirus vector, which is a virus that has been rendered inactive and that is not harmful. And this virus sort of brings the genetic information into your cells that is telling it to temporarily produce the spike protein, similar as the mRNA vaccines. But it's really important that this virus has been engineered to not be able to reproduce, meaning that it will also not change your own DNA or your own genetic information in any way, shape, or form. But by sort of allowing your own cells to dress up as SARS-CoV-2, it triggers your immune system to begin producing antibodies and activate other immune cells to fight off this pseudo infection that the vaccine is causing. Again, the vaccine does not cause real COVID-19. It does not cause infection with SARS-CoV-2. It just triggers our immune system to sort of think that there was an infection to help it produce the antibodies to fight off, the real virus if your body ever comes into contact with it. Another question that's been asked really frequently is, what does this help? Do I still have to wear a mask and practice social distancing after being vaccinated? And the answer to that is yes for now. We all still need to do our part and continue to wear masks and stay socially distanced until most of our community has been protected with the COVID-19 vaccine and COVID-19 rates are sufficiently low. This also really protects us from variants and from the spread of variants. So it's still really important to wear a mask and practice social distancing when meeting up with people outside your household, unless they too have been fully vaccinated. If I have been vaccinated and get sick with COVID-19 symptoms, do I need to get tested? And the answer to that is yes. There are very few cases of people who have gotten sick after receiving the COVID-19 vaccine, but it is possible. So if you get COVID-19 symptoms, please get tested as soon as possible. A related question I've been hearing a lot about is, if I have had the vaccine, will that, change will I test positive because of the vaccine? And that is not the case. So in general, if you're doing a PCR test, that really tests for the virus, not the vaccine. So if you've been vaccinated and you test positive, then you should assume that you actually have COVID-19. Okay, next, let's see, I can do this myself because of the Zoom remote control feature. Okay, will the vaccine be effective for all the COVID-19 strains? Well, the good news is that the available data suggests that the vaccines we have currently on the market, so the vaccines that have been authorized under the emergency use authorization, actually do work against the variants known to be circulating in the US currently. So we've heard a lot about this British variant, which is now actually the dominant strain in the US, but the vaccines on the market have relatively good efficacy for these strains. However, vaccine makers are starting to prepare for the possibility of updating the vaccines to protect against emergent variants. And updated vaccines could potentially be given as booster doses. So this is a reality that I think that we should all be mentally prepared for at this point in time. Well, if you can still get COVID, why not take my chances with COVID-19 instead of getting vaccinated? Well, my answer to that would be that COVID-19 is by far the more dangerous option. Although people who are older, obese, or have other health problems are at the highest risk for complications from COVID-19, we've also seen a lot of young people get ill. And we've also seen young and old, as many as 1 in 3 people who recover from COVID have chronic complaints, including exhaustion, racing heart, that is worse for months afterwards. And some of these folks who are so-called COVID-19 long haulers had minimal or no symptoms upon initial infection. COVID-19 vaccines, in contrast, are very, very safe. Okay, another great question. Should I get vaccinated if I've already had COVID-19? Well, our body's natural immunity to SARS-CoV-2 wanes, meaning that it just becomes less. So reinfections are possible, and that's probably something that you've heard a lot in the news. This is why vaccinations should be offered regardless of history of prior symptomatic or asymptomatic infection. The CDC does not recommend a specific interval between recovery from SARS-CoV-2 infection and vaccination, but current evidence does suggest that the risk of reinfection is pretty low in the months right after you've had the initial infection. So for that reason, people with recently documented SARS-CoV-2 might choose to temporarily delay their vaccination, meaning that if you've had documented COVID-19, so if you've had a positive COVID-19 test over the past few weeks and months, you could choose to temporarily delay your vaccination. But again, there is no recommended interval, so you can get your vaccination pretty much as soon as you've recovered. Will the vaccine be effective? We have actually already addressed this question, so I'll move on. Oh, another big question that we are seeing is, should I get vaccinated if I'm pregnant or breastfeeding? It's important to realize and talk about and be honest about the fact that vaccines currently available under the emergency use authorization have not been tested in pregnant women. So there have been no studies specifically looking at the vaccine safety and efficacy in pregnant women. However, pregnant women all across the country have been receiving these vaccines, and they also did receive these vaccines in the trials because some women entered the trial prior to knowing that they were actually pregnant. And based on a rigorous review of all the available data and based on the science of the current vaccinations on the market, the American College of Obstetrics and Gynecology recommends that COVID-19 vaccines should not be withheld from pregnant individuals, meaning that pregnant women should be offered the COVID-19 vaccine regardless of their pregnancy status. Similarly, they should also be offered to people who are breastfeeding. pregnant or breastfeeding people should have access to available information about the safety and efficacy of the vaccine, including about the things that we don't know, right? So for anyone who is making that, very personal decision for themselves and their family, a conversation with your clinician can be helpful, but it's not necessary. So essentially, this is your own choice. This is your own choice to make, but based on all the available data and the science behind the vaccines, they are very, very likely to be completely safe. And I would also like to note here that pregnant people are at higher risk of suffering severe COVID-19 disease outcomes, making it particularly important in that population to have protection. When can my kids get vaxxed? Another one of those big questions. At this time, only those aged 16 or over are authorized to receive the Pfizer vaccine, and only those over 18 or 18 and older are authorized to receive the Moderna and Johnson vaccines. However, the good news is that there have been some recent clinical trials that documenting the Pfizer vaccine to be very effective in children aged 12 to 15. During the clinical trial, no symptomatic infections were recorded among the vaccinated, and both Pfizer and Moderna have begun testing their COVID-19 vaccine in babies and children under 12. So there's a lot to come here. There will be a lot of questions asked and a lot of decisions to be made. So I think we're all awaiting that eagerly with anticipation. Let's stay tuned. Let's see. Okay. All right, what do I need to know about the pause of the J&J vaccines? So this has been something that has been very heavily debated on the news. I think almost everybody has heard about this pause. There's very high public awareness of this. So based off the fact that 6 women under 50 developed blood clots after receiving their shot, US authorities have recommended pausing the use of the J&J vaccine to investigate those cases. So it's important to note that this is really only 6 women among 7 people who've received the Janssen's vaccine, meaning that it's actually more likely that you'll be struck by lightning in the upcoming year than have this particular side effect from the vaccine. That being said, it's really important and demonstrates, the rigor with which public health officials and medical professionals are sort of investigating this vaccine. And a recent study that actually I think was published this morning, survey study showed that among the general public, this pause in the J&J vaccine is actually increasing trust in vaccines. So unlike we have been worried about, people are, I think, really understanding that this pause is necessary and important for investigating the cases, but it's not looking like it's decreasing trust in vaccines. So that's a really good, some good news. And if you hear, I'm in my ancestral territory and the dogs are barking all over. They always have conversations amongst each other. So just FYI if there's stuff going on in the background. So, question about the J&J vaccine. Does this mean the vaccine is unsafe? So no. On balance, the vaccine is safe for most people and will not cause any severe adverse events. Actually, in Europe, I think this vaccine is in the beginning stages of being on the market, offered and on the market again. But for now, this pause and data review will really give us an accurate information on any positive side effects, even the rare ones. And again, it's really important that we're all responsive to any safety concerns. And the FDA and CDC have a lot of systems in place to find, report, and investigate any adverse effects, even if they turn out to be completely unrelated to the vaccines. Now, one question that I've been getting in my community a lot actually is, ooh, I've had no side effects. Does this mean my body isn't responding to COVID-19? So I think that's a really interesting one. And I think that has to do with a lot that, in the public space, we've been talking a lot about all these different potential side effects. So people are worried that, if they don't have any side effects, that means that their body isn't, building an immune response. So to that, I will say that although it is common to develop side effects after COVID vaccination, including a slight fever, headache, nausea, or fatigue, if you didn't get any side effects, that doesn't mean the vaccine isn't working. In these large clinical trials that Nina was talking about a little bit earlier in our presentation, actually over half of the participants didn't have any side effects at all, but they were still 90% protected after receiving the vaccine. So if you don't have side effects, it's not necessarily a bad thing. Hang tight and enjoy the fact that you did not have side effects. And then sort of a related question is, how should I prepare for my shot? So in general, there's really nothing specific people should do before vaccination. It's not recommended that you take a Tylenol or over-the-counter meds prior to getting your shot for the general population, but you may want to keep these meds ready for managing side effects if that's something that you do normally. It's really important to give your body plenty of rest, healthy foods, and water, and that'll really help your body mount an immune response against SARS-CoV-2. I think this is also maybe a good time to tap into our traditional medicines. Me and my family had a lot of elderberry tea at the time of receiving our shots, and similar, there are a lot of really great plant medicines that can sort of help our immune system. None of this is really evidence-based guidelines, so I'm not speaking as the CDC here, but I think this is a great time to sort of tap into our traditional medicines toolkit as well. Is it true that receiving the COVID-19 vaccine can help so-called COVID-19 long haulers? So this has been a really positive story we've seen on the news, in the news a lot. There was a preprint UK study that found evidence that after so-called COVID long haulers were vaccinated, they felt better. So, and what I mean by long haulers is those folks who months after having COVID-19 are still experiencing, fatigue and other related symptoms. There have been a lot of anecdotal reports from COVID-19 long haulers that sort of confirm this theory. However, more research is needed to know if it's really the vaccine that's helping, but I think that's something really encouraging, because prior to this news, we really didn't really have any tools in the toolbox, or meaning a lot of tools in the toolbox to help these folks. So if it's the vaccine that's helping them, that would be really great. And then we have this COVID strain question again. I don't know how that got into so many slides. It's the sneaky question that keeps coming back. Okay, so that is it for our presentation. Yodwa, thank you. We are geared up to answer all of your burning COVID-19 questions. Let me check in the chat. I am wondering if we already have some, but feel free to unmute yourself. Feel free to drop questions in the chat, and we'll do our best to respond to them.
Sophie, we got one question from Dan about why do you think there has been such a high vaccination rate in Navajo Nation? So maybe Nina, I don't know if you want to speak to that.
Sure. I think it's funny because Dan is also a study physician out here. We are colleagues. So I bet Dan can also answer this question for himself, but I'm happy to answer. So I think that the sense that we get about the distrust, I think that can be an inherent part of kind of the life experience of individuals and Native communities. And I think that there probably is, I think we see this in a lot of social media groups. There's this vocal minority. So pretty much the people who are the dissenters are probably going to be the loudest and are going to, take to social platforms, and they're going to voice those opinions. And so we see this all the time on President Nez's Facebook page and in his town halls and in his posts, that the vast majority of people who are commenting are actually commenting disdain or skepticism or disapproval. And I think that that is a smaller minority of people. And I think that probably the majority of people, do really support vaccination. They see the value in what role that serves in ending the pandemic. And I do think that the majority of people, even though there is this potential distrust or worry that there's experimentation or, that their best interests are not at the forefront, I think that many do understand the role that vaccines are playing in protecting their community, protecting their elders, protecting their culture. So I think even though it seems like so many people are speaking out, I think it's because it's the smaller vocal minority that is speaking out, and that the vast majority are actually supportive and have gone to the drive-throughs and received their vaccines and have brought their grandmas and grandpas and tried to make sure that they're protecting their family.
I think just to add on to Nina's point, I think some of the other things that we've seen, I think outside of these communities, because I don't work in the Native American population, but what we have very much found is that individuals that are essentially experiencing higher rates of morbidity and mortality related to COVID, that has also been a huge persuasive factor for them to get the vaccine. So I've spoken to individuals that have been very anti-vax generally is the way that I would conceptualize and categorize these individuals, but then they have seen what it has done to a family member, and that has really shifted their thinking. I think the most important piece for me is to have a better sense of, is that going to be, are we going to continue to see this essentially? So when influenza season comes around, one key thing for those of us that study hesitancy and behaviors, we had an incredible influenza season this last season. And that's simply because people were masked up, people were home, people were not hanging out with other people. So there was less likely to be respiratory droplets in the air. So it'll be very interesting to see this fall when things are changing and we're having a higher proportion of the population here in the United States fully vaccinated. Are we going to continue to see people still we have very, very low rates of influenza vaccine coverage now. Less than about 45% of the general population gets a vaccine related to influenza. Last year, we saw a huge spike in that. And so most of us are very curious because of morbidity and mortality related to influenza and complications related to influenza. Will we see something similar moving forward? Great question.
Wonderful. Thank you so much, Nina and Rupali. I have another question. I've heard this one a lot. I've seen a lot of younger childbearing age women hesitant on getting vaccinated due to being afraid of the vaccine having effects on their fertility. Is there any evidence of this yet?
I can quickly comment on this. I run a large project that's looking at pregnancy and breastfeeding and how we are conferring antibodies essentially. And this study is actually taking place. We're in the process of doing data collection in Kenya and Bangladesh. And I think Sophie mentioned this. A lot of it in the way that it's working in the United States, pregnant women was not an inclusion criteria for the clinical trials, right? So if we happen to track you because you happen to be pregnant or you took it, and then you got pregnant afterwards, that's through a registry, right? So that's not through a representative sample that we're essentially pulling on to understand what are the adverse events, if any, and does efficacy change? I think one thing that's very curious and what is very interesting to me, I would say, is that, some of these myths that we're seeing are very similar to those of us that have been working in this space that we've heard for a long time. So for example, I work in Pakistan and Nigeria where polio is endemic. And the number one reason why younger women do not get the polio vaccine is they're afraid it will impact their fertility. And so to me, it's a myth that's now just shifted really, right, to affect and sort of transform itself to the context of the current pandemic we're dealing with. I think one thing I will say with certainty, there is no evidence that would say that there is a link between exposure to the vaccine and any sort of fertile reproductive health issues. I don't know if Sophie, because I know we have an OBGYN in our midst, if she also wants to comment on this. So maybe I'll stop talking and hand it over to her.
Oh, absolutely. I want to say I'm an aspiring OBGYN, not an OBGYN yet. But I actually think that a good way to look at that particular myth is looking at why, the sort of reasoning that people are giving for that myth. And so a lot of what I've heard is people are concerned about a specific spike protein that we find on the placenta. So there are all different types of spike proteins. There are many, many, many different types of spike proteins, right? And some of these spike proteins happen to be in our placenta, in cells in our placenta, basically. And so people are concerned that because these vaccines help you generate antibodies against the SARS-CoV-2 spike protein, that will sort of somehow result in our body like generating immune responses against our own placental spike proteins. Well, the way you can kind of look at that is imagine every spike protein as a key, right? There are lots of different keys, but not every key is going to fit in the same lock. Similarly, there is no way that the spike protein in our placenta will sort of generate the immune response that we've trained our immune systems to mount against SARS-CoV-2, the novel coronavirus. So that was a little bit of the nerdy biological explanation, but I think sometimes it can help when you sort of address, some of this misinformation, even just for yourself.
Wonderful. Thanks so much, Rupali and Sophie. Nina?
Can I also mention that VAERS, which is the Adverse Events Reporting System for the CDC, that information is actually available on pregnant women who have received the vaccine under emergency use authorization, so both Pfizer and Moderna. And that's actually really favorable. If you can see the kind of breakdown of potential outcomes for pregnancy. And it's actually not different than the general population. There's no significant difference in like miscarriages or stillbirths. So that's actually really reassuring. And that is data that the CDC has collected through the VAERS program. I don't have a link for it, but I think it's easily Googleable, or I could try to find it.
Thanks so much, Nina. I'm going to respond to some of the common questions about the slides and the availability of the webinar. And so I think our wonderful team member, Kathleen, has been taking down emails for people who would like access to the slides and the downloadable webinar after this meeting. The webinar has concluded, but we also will provide those materials for you direct to your email after the webinar. So don't worry too much about requesting them. We can provide those to everyone who attended today. All right, and I think we do have another question that has come up. How would you address vaccine hesitancy now that there are breakthrough cases? So let's see, Rupali, I don't know if you want to respond to this first.
Yeah, and breakthrough cases meaning after getting vaccinated, still getting infected with COVID, right? Just want to clarify. That's what the participant.
Yes, I think so.
Okay, yeah. One way, it's so interesting. I'm not sure if you guys saw, there was a piece that came out, I think, on CNN just last week, and several of us have been doing all of these really fun media tours where they're asking us to essentially comment and talk about how do we communicate about the J&J pause, right? The flip side of this, and one way I would think about this, and I'll relay it to your question, is that, so if we had 6 cases out of 7 million doses, let's flip that around. That means we had 699, whatever it is, right, million that had no adverse events. And so I think of it in the same way when I think about these breakthrough cases, simply because one, we know the vaccine is not 100%, we know it's 95%. The second issue that we're dealing with here is the variant issue. The B117 is wreaking havoc currently here in the United States. And part of that issue is that it's more transmission efficient, meaning that even if all other precautions are made, more people are going to get infected. And so I think that the fact, I would flip that around and I would instead say, out of all of these individuals that have been vaccinated, this is how many people did not get COVID, and I think it's really challenging for people. I study persuasion. I teach a class called Persuasion, and it's really hard for people to understand and quantify and think about risk, right? I think we think about odds and we say, we see a plane crash and automatically we say that could happen to me. And when you really think about those odds, right, strategically, you know that the chances and the odds of these things happening are pretty low. But again, these are based and developed at a population level, right? Because this is a public health intervention. And so I think it's really hard when we will continue to see cases, right, even after being fully vaccinated. And that's why it is so important, though, because we're just getting data related to, the vaccines were essentially developed to prevent you from getting it, not necessarily prevent you from passing it on. What we have found over the last several weeks is that we do have pretty good data that now show that it reduces transmission, right? So, which is incredible. That's an extra, to me, that's like a value add. Part of the miracles of these vaccines is that not only do they prevent you from passing it on to someone else. But with that being said, there still is that small risk, and hence why we continue to recommend still wearing a mask, continuing to social distance if you can, and staying home until we reach this magical threshold of community immunity, which is a moving target, unfortunately, because of the second variant that is also starting to wreak havoc here in the United States.
And I would also add that it's really important to emphasize that even with these breakthrough cases, how many of them were severely ill? How many of them actually required hospitalization or an ICU stay or died? So like really, I think, at least for me, is that the point of these vaccines is to primarily prevent severe illness and death. I think that's number one, my number one goal. Number two is to actually reduce the number of infections and reduce transmission. And it does that. We have data that shows that. So, I mean, I think it's really great, to get those questions. I think it's great people are asking those questions, and to just, provide them the information that yes, breakthrough cases are going to happen. It's a very small amount. And of those breakthrough cases, those folks are not severely ill. And if they are, it's very, very rare occurrence. Just like Rupali said, flip it around. The number of people who are not severely ill, from COVID after getting vaccinated.
Wonderful. Thank you so much, Rupali and Nina. I know we are coming up on our time limit, so I'm going to pass it back to Jenny Richards. And just to really quickly answer a few more of the questions, yes, a recording will be emailed out to everyone who attended today. So thank you for that.
Yeah.
Dr. Richards?
Yeah, thank you, Anna. Go ahead to all of our speakers, Dr. Ritchie, Dr. Nooner, and Dr. LeMay. We want to thank everyone for joining. I just want to remind everyone that there's going to be a brief poll again. It'll be very short. We're asking everyone to do this really quick before you sign off. Also, there'll be a follow-up email where we're going to talk about some of our other events in the series. We would appreciate it if you do the very brief evaluation. We want to know how helpful these webinars are, and we also want to know what to talk about on the next few webinars. So some of the questions that you didn't get answered, if you could put that on the follow-up evaluation, that would help us kind of steer where we're going to go with our next webinar. And then you can also include concerns within the community. And then last, we're going to have a town hall on COVID vaccine hesitancy on May 13th. So please look at the follow-up email for more information on that. And thank you everyone for joining. We really appreciate it. Have a great day.